Good afternoon, Ben.
Hi Joe, how you doing?
Yeah, really good, thanks. How are you?
Excellent.
So, um, welcome everybody. Do come on in and join us and let us know in the chat where you are joining us from. We love to know where our audience is in the world, all the different time zones. Come on in, welcome, welcome. Oh, Marie, second time in a week. Hello, nice to see you again. Nice to have you here. Anna from the Netherlands, welcome. And Hilda from Belgium, hi. Hi, hi, hi. Welcome. Okay, that's great. Thank you. Come on in, everybody. Lovely. How's the weather with you, Ben?
Currently, it's quite sunny. I start a holiday up in North Wales tonight. We're heading up to North Wales where gale force winds are predicted.
No way.
So we're going for a week of hill walking, and it's going to be blowing a gale force winds for the next few days. So
Oh,
we'll see how that goes.
we've had such amazing weather, haven't we? And
Well,
just,
it's
oh,
half term, isn't it? School holiday start, weather craps out.
yeah, totally. Oh my goodness. Yeah, it's sunny here in North Yorkshire. But I think it is due to break tomorrow, but we could do with a bit of rain, actually. So it's not a bad thing. Oh, hi everybody. So welcome, welcome. Lots of people from Greece, Wiltshire, London, Ireland, Austria, Slovenia. Oh my goodness, absolutely brilliant. Thank you for joining live. Thank you. Okay, so we're going to kick off because we inevitably run out of time in these sessions. So I have an intro that I like to just run through so everybody knows the protocol. Um, so Hello, and a very warm welcome to this Noigroup clinical discussion. My name is Joanna Taylor, and I am Director of Noigroup Europe. And I'm joined this morning by my very good friend, Dr. Ben Davies. Ben has been a Noigroup teacher for well over 15 years, and he has taught hundreds, well, I'm saying hundreds of explain pain courses, I would say,
I think
to
so. Yeah.
thousands of clinicians all over the world. He is an active clinician himself, currently working in the NHS. Ben, would you just tell us a little bit about what you're currently doing?
I'm a physiotherapist. Have been for 25 years. I work in Bath in the southwest of the UK. I work at a trust, RNHRD, Royal National Hospital for Rheumatic Diseases. So we specialise in rheumatology, and we particularly specialise, or I particularly specialise in axial spondyloarthritis. We run a 2 week rehabilitation course for AS. People come from across England and come and stay with us. It's the only one in the country. Um, so we have a group of people who are here for a 2 week stay for this particular condition.
Thank you. You know why I ask you to say that bit, don't you?
You
Because
can't
I can't
say
pronounce.
axial spondyloarthritis
I did
all
try
these years ago.
once, failed. Okay, thanks, Ben. So these sessions are all about giving you a taste of explain pain and how to practically use it in the clinic. Some of you will have already done an explain pain course, and for those of you that have, these sessions are designed to reinforce what you have already learned. But if you're new to NOI, new to explain pain, this will give you a really good taste of what is covered in the core course. So Ben does have an explain pain course coming up on the 10th and 11th of July. And if anybody is interested in attending that course, we'll be talking a little bit more about that at the end of the session. So do just stay on if you've got any questions about that. And I will drop the link into the chat if you want to click through and take a look at that. Um, so just a couple of practical things before we start. Ben and I will be talking for about 20 to 25 minutes. If you have any questions, please ask them either in the Q&A or the chat, and I'll monitor those and ask them at an appropriate time. And if you want to watch the recording of this session, you can access it in the clinical discussion YouTube channel. And the link for that will also go in the chat when we kick off. So today we're talking about navigating pain flare-ups and teaching patients self-management strategies. So Ben, just to start with, could you tell us the sorts of things you're going to cover, and then we'll kick off with some questions.
I think we're going to think about what a flare looks like, what it might be, and I'm going to, although I work in rheumatology, we'll try and keep this, as broad for anybody who has, everybody on this call manages people with pain, but is it a pain flare, a fatigue flare, other symptomology? So what do flares look like, and how do we help people? I think, and I'll use words like, how do you have a bird's eye view of your symptoms and your contributors? Why is this getting worse?
Okay.
But also and then of course, what can you do about it? How do you
Okay.
reduce that pain flare, symptom flare, make it less severe, make it less long, make it happen less often? That's what we're
Great.
after.
Thank you. Okay. So let's start with the very basics. What exactly is a pain flare up?
I probably wish I knew, in all honesty, Joe. I don't think it's really very clear. In rheumatology, we can't really be precise about this. The research community can't articulate exactly what a flare is. So in some ways, a flare is whatever the person says it is. I think in my experience, we see people, and I mean this outside of rheumatology as well, you'll see people who have pain flares that are short and sharp. Something flares for pain flares for a few days, and then it settles back to their, maybe nil, or it settles back to their sort of baseline. You get some people who flare for longer. They might flare for weeks or months, and sometimes people will say this, I'm in a flare and I've been in a flare for a year.
Mm.
And sometimes those people, again, eventually come back to their baseline. Third group, I think, is people who flare, and even though things improve, they don't quite get back to baseline. The challenge, I think, for the flare, though, Joe, is in rheumatology, flares don't correlate well with things like imaging studies. So if we re-X-ray people, we re-MRI scan people, the imaging can often look no different than it was in their non-flare. Blood tests don't necessarily change. Inflammatory markers don't necessarily change.
Mm.
Outside of rheumatology and musculoskeletal sort of pain flares services, you, as a clinician, you're not seeing the reason why. And I suppose what that leads to is this lack of clear relationship between person's experience and necessarily what's going on purely in their body.
Mm. Mm.
So we don't always know. We can't really define a flare, but working with a group or working with an individual, I would take it from them. Do you think this is a flare? What do you think's, well, this is probably the next question. What do you think's contributing to it?
Mm. Yeah. Yeah. Oh, you will. We'll just go straight into that. So, what are the most common triggers and contributors to flare-ups that you tend to see?
I mean, we've opened this discussion talking about pain, and a big part of explain pain is recognizing that pain is this evolved experience and it's there to warn us. And oftentimes that pain experience is accurate and it's useful, but sometimes it isn't so useful. So I think we can, pain brings people to our services. Pain brings you to see a clinician very often.
Mm.
I think broadening the idea of what a flare may mean to people is recognizing that a flare may be fatigue increase. It may be slightly worsening gut symptoms like early IBS or flatulence or bloating. It might be redness and swelling around a joint. It might be slight changes in their mood state. I'm a bit more grumpy than I'm used to being. I'm a bit more
Mm.
hair triggery with friends and family. I'm a bit more, you know, I just feel a bit under the weather. Everyone on this call has had flu at some point or COVID. That just a little bit off your game. Those things
Mm.
can all be pre-flare symptoms, perhaps. So, can we help people understand what's contributing to them? And I feel there's four questions that we try and ask people. And I may be repeated, people have come to these things before. I feel like this is a thing that I'll say often to people, but is there a really obvious physical trigger? Have you obviously done too much? Have you obviously done too little? In rheumatology, that leads to stiffness and
Mm.
being too sedentary. If you've done too much, you need to calm down a bit, pace a bit more. If you've done too little, you need to move a bit more. So those things, I think most people with pain, you know, they're not stupid, are they? They recognize if they've pushed too hard.
Mm.
But sometimes they don't see that pattern. So then there's the next question is, has there been something really obviously emotional slash psychological slash stressful in life?
Mm.
Work pressures, relationship breakdown, illness in your children, illness in your parents, increased caring responsibilities, um, other illnesses, stuff, bereavement anniversaries. These things are all, people may not recognize that those things can be significant contributors to pain,
Mm.
fatigue, grouchiness, all the things that we've just touched on. They may feel they're not valid causes for symptoms to change and flare. I
Mm.
think part of our role is to highlight that those psycho and social factors are absolutely relevant.
Mm.
Third question is, are there micro triggers? You have little things, and the analogy I'd use, I've got a whiteboard just to my left here. I would use a whiteboard. I draw a bath type, beaker type thing. And what's filling your beaker?
Yeah.
You've got a busy life, Joe. You've got young, not so young kids now. You've got family, you've got parents, you've got jobs, you've got
Yeah.
income considerations. Are all these things just building up a little bit? How do you manage stress in life? You've got a sort of outflow, you've got a plug hole in the bath that helps you manage stress, same as I do. And we do that
Mm.
through laughter and closeness and exercise and feeling in control. Well, and maybe some yoga and maybe some breathing and maybe some
Mm.
relaxation. If those two, the things that are filling the bath and things that are emptying the bath are in balance, great. But what's changed? Has there something changed? Have you got more stresses just filling up? Has something plugged your plug hole?
Yeah.
You're not managing that stress in quite the same way.
Yeah.
That big picture idea or bird's eye view is what's going on here? You know, medicine is really good at looking inwards, isn't it? Medicine's really good at focusing in on blood
Mm.
tests and imaging and objective examination. But can we also help people step back a little bit and view what's
Mm.
going on? Because then can you then have a management for each of those contributors? Some might need drugs, some might need exercise, some might need talking, some might need breathing and relaxation. Fourth option, this is the hardest one, pain has a mind of its own, and it seems however much somebody interrogates themselves and journals and diarizes and tries to look for links, sometimes symptoms just flare.
Yeah. Okay, that's super interesting. I like that. So that you tend to draw that out, do you? So visually.
Yeah, it's really bad drawing, but I just draw a beaker or a bath with a tap
Yeah.
and a plug hole, and you can layer up the line in the bath as it fills up, and you can just layer in sort of work stress, life stress, family stress, relationship stress,
Mm.
just what's going on in life. Everybody,
Yeah.
all of us on this call have complexities in our lives, don't we? So we're just the same as people who come to see us.
Yeah. So it's a good strategy, like simple, really, for people to understand all those sort of different stresses that are in their lives that they don't always appreciate, are there.
I like Marie. Thank you, Marie. Bad drawings are better. Yeah, thank you.
Yeah.
It doesn't have to be perfect. It just has to be that idea that you're trying to articulate. And drawings are, yeah, they're
Mm.
useful.
Yeah, memorable. I'd agree, Marie. I think that they're often more memorable, especially if you've done them yourself or your patient has done it themselves. They're going to remember it better, aren't they? That's a lovely practical strategy, Ben. Thank you. So moving on then. So once you feel that a patient has understood their patterns and the things that might be going into their cup, how do you work with them to create personalised management strategies that they can implement themselves?
So that, I mean, that's very going to depend on what are the triggers. And Joe, in your, our sort of pre-meeting prep, one of your questions is around DIMS and SIMS, this idea
Mm.
from Noy around danger in me, things that are threatening to me, safety in me, things that are sort of calming to me, give me groundedness. That's really another way of saying this idea of bucket filling and bucket emptying, the balance.
Mm.
But I think if you can understand what are someone's DIMs, what are the things from a biology perspective, from a psychology perspective, social perspective, that might be one lens that you look at it through. People might be familiar with DIMS and SIMS, or they've seen other podcasts from and webinars from Noy, or looked at the protectometer. Are
Mm.
these smells and images and ideas that are quite threatening? Are these people in your life that are quite, tension developing in you? Is it a context of work or a place that you bypass or you have to pass through where you were injured in the past? These
Mm.
things are all to kind of recognize and have a narrative around. But then I think we also have to think, well, how do we change that? How do we And how do we help someone get that understanding that that's relevant? And then what is the appropriate management for each of those? Which is a physio? What's the role for physio?
Mm,
Through exercise, through stretches, through some relaxation. If you're an occupational therapist, you've got a different skill set to manage a different constellation, perhaps, of those contributors. If you're a psychologist, you've got a different constellation of skills to manage a different sort of set of those contributors. As clinicians, we've got to recognize, can we deal with some of those, all of those? Who do we
mm.
need to get involved to deal with those things? So it
Yeah.
becomes very individualized, and clinicians on this call need to recognize who are there, who's in their professional network, who's in your multidisciplinary team, who do you refer to for things like talking therapies or more psychologically targeted support.
Mm, absolutely. So I don't want to put you on the spot here, but and this because this wasn't in our prep, but have you got any examples of something that might be quite common? So one of the sort of the triggers, the emotional stressors, micro stressors, and pain having a mind of its own, and then a patient who has embraced the idea of the cup, and you're working with them to help them to create that balance.
I think so. Yeah, one person comes to mind. They're a teacher. We all, you understand the life of a teacher. You have parent-teacher evenings to do, and you're in a
Yeah.
mainstream school. You've got 30 odd parents to meet, and the school strategy was to do this across a week, five or six parent groups, meetings every after school, every evening,
Mm.
online, I think they were. And when the person did that, you're a dedicated professional. This is how the school is. This is the sort of idea. When you did that, they inevitably ended up flaring. Their AS flared. They would be off work for a week or 2 weeks. Then the school have to get in, supply
Mm.
teachers. The continuity of teaching is broken. So one of the really important skills, which people need, is communication with others. So this lady communicated with her head teacher, talked about the stresses, communicated a better way of managing. This is basic pacing, isn't it? To spread her class teacher evenings across 2 weeks, 3 weeks.
Yeah.
Okay, it takes longer, but the impact on her bucket filling was significantly less. It was manageable. No flare, no pain flare, no requirement for sick leave, a much better outcome for everybody. But it did need that negotiation and planning. And I think that's a
Mm.
really important skill that people need, is to share a plan.
Mm.
So
Yeah.
often, so often people do hold these things, they kind of hold them within, don't they? We will say so often pain is invisible and fatigue is invisible,
Mm.
and how do you communicate your needs? How do you ask for support from a significant other, from your partner, from your work colleagues, from your employer, from whoever else? So communication is a really important flare management
Yeah.
strategy.
Yeah. Oh, and simple as well, one that might be overlooked. So Eugenie, thank you for your question. I think we'll take it here. This seems like an appropriate time. So Eugenie says, I have a client whose pain flare-ups significantly when she feels ashamed or rejected. These emotional triggers seem to be strongly linked to her physical symptoms. Could you offer a neurobiological explanation for how feelings like shame, social rejection can intensify pain? And how can I explain this connection to the client in a way that is accurate and easy to understand?
Um, Neurobiological, perhaps not. I think I might be grasping at straws to talk about the neurotransmitters of relevance and the neural pathways of relevance.
Mm.
And I think if I'm grasping at straws, then my explanation, and this, Joe, I think is a key kind of part of explain pain, isn't it? If I'm slightly grasping at straws, then Eugenie, as someone who's listening to it, is not going to feel that I really know what I'm talking about. But the
Mm.
idea of using everyday examples. So if I asked Eugenie, Eugenie, remember the time in your life you were most embarrassed. Remember a time you did something wrong, perhaps, and you were really embarrassed about that, or ashamed because you'd done messed something up. If you recall that experience, could have been an experience from decades ago, perhaps.
Mm.
If I rethink of a time when I've been mortally embarrassed about something I've messed up, how does my body feel? My stomach will flip and my hair will stand on end, and I might even feel that physicality of, again, because this is linked to this.
Mm,
My memory of a really embarrassing trauma experience, or a time when I was rejected by somebody or something, resonates today if I relive that experience. I think lots of the sort of stories through Explain Pain are very much around normalizing the experiences people have. Now, yes, maybe people's experiences might become kind of towards the extreme, as in feeling pain may not be what I'm going to feel if I remember being embarrassed. But when you've got pain as an experience that is protective, that wants you
mm,
to change the scenario that you're in and alter your behavior, then if you're in a situation that's embarrassing, emotionally upsetting, then it sort of makes a lot of sense that pain flares to say, stop that, change that, withdraw from that scenario, that situation, do something else. So now that isn't a neurobiological explanation, but it's possibly an explanation that's really familiar to everybody who's listening to this.
mm. So do you think that it's just in asking the person to re re notice what's going on with them when they have those emotional feelings, and that then correlates to the flare, like awareness?
I think in the research, so one bit of research I think is that I agree with you, Joe. It is this sort of slight, almost like pre-flare awareness.
Mm,
In rheumatology, Nicole Tang's a sleep researcher based in Loughborough, I think, and her and her group did a long study around using sleep trackers and flare diaries and all sorts of things.
mm,
The people who were involved in the study just said like, today's a flare, today's a not flare day. And the only thing that really correlated with the likelihood of then saying I'm in a flare was disturbed sleep.
mm,
Now, that wasn't a really strong predictive value from that statistically, but it was the only thing that really began to sort of put its head above the parapet that if you've had a couple of nights when you say sleep wasn't so good, or your sleep tracker, recorded less good sleep, you were more likely to sort of trigger the I'm in a flare button within a few days.
mm,
So, but everybody has times when they go, "Oh, I've not slept so well," and you push through. "Oh, I've not slept so well again, push through. Maybe that awareness, and it might be sleep. Maybe for some people it's gut. Maybe it's for some
mm,
people it's feeling grouchy or under the weather. I'm just okay. Let me pay attention to that. Okay, can I just switch this down a little bit? What are the wellness behaviors? What are the good things? What are the restorative practices that I can put in place to sort of offset a flare, even perhaps ideally before it even happens?
yeah.
Or if
Yeah.
it does still come, will it be less severe, less long? That's a good outcome as well.
Thanks, Jen. That's brilliant. So we'll just take this other question here quickly. Is it normal that when you're coming out of a pain flare, neuropathic pain, exhaustion hits harder?
Yeah, I think so. I think
Yeah.
being in pain is really hard work. Pain is not just a simple singular system. You will be, any of you who are in pain, you'll be having all of your systems are in that slight upregulation, call it fight flight if you want. You're
Mm,
thinking a bit harder, you're trying to work out what to do. Life is harder, your sleep is probably, less good. And I think as things calm down, a bit like when you come out of a fight flight response, you then
mm,
have that,
yeah.
crash feeling.
So yes,
So,
that
so
is
yes, I
normal.
think it's certainly
Thank
not
you.
unusual.
Thanks for the question. And we're just moving through our questions here.
Well,
So
Joe, can I pick up one thing because
sure.
I'm aware of time and I wanted to make sure. And you've mentioned the sort of SIMS, the safety in me factors. One
Yeah.
of the things I think that's really, I think clinicians often miss, and I know I'm guilty of it, is and almost the nature of this webinar is set up to think about flare. So again, if I would draw this up on our whiteboard, timeline, pain is bubbling along. I have always worked a long time working with people with persistent pain. So pain's bubbling
Mm,
along, but it's manageable. It's two out of 10, 3 out of 10, whatever. It sort of doesn't matter the number, but it's manageable. And then life course happens. Pain flares, pain calms down, pain flares, pain calms down. People have got this variation in their pain across years and decades. clinicians, I think, are really good at asking about, as we have done, what causes a flare? What's leading to this to get worse?
Mm.
I think what clinicians are less good at doing is asking, what was going on when you were better?
Yeah,
What was going on when life was actually going quite well? Maybe you were at baseline, maybe you're a little bit better than your average. So there will be times when your pain record, if you like, was actually better than your usual.
yeah,
I think we often focus on the sort of contributory factors for a flare. What we maybe don't focus enough on, and I think this feeds into things like SIMS, wellness behavior, or preemptive self-management, is what was I doing when things were good? In fact, it's been rubbed off. My last group came up with the term self-carishness. So when we were talking about being selfish, is it selfish to practice your exercises, to relax, to ensure good sleep hygiene,
yeah,
to make time to see friends and have a belly laugh with people, to have times of intimacy with your partner? Is that selfish or is it self-carishness?
yeah. I love that.
So self-care, I think we just often miss the sort of better side of this equation. And I think we should
I
really be
agree.
encouraging people to, again, big picture, when life was good. Well, I was going to the yoga class and I was meeting up with my friends for coffee and we were eating a really healthy sort of home cooked diet. Do you know what? Actually, yeah, we've had to have more takeaways recently. We've had a bit more ready meals recently. The yoga person moved away and I haven't really found another class and fell out of just making those plans with friends. Actually, those are the
Mm.
things that we've just lost. So there's two sides to the flare equation, I think. There's what makes it worse, there's what makes it better, but there's what makes life better overall. And I think we should really pay attention to that stuff.
And that I agree completely. And I think it's a really, really subtle but really important reframe of looking at, you know, the positive side of it. And that sort of covers what we were going to talk about next, which was building resilience in people, so that they're looking at self-carishness and the changeability, when it's not as bad. And I think it's one of the things I actually love about the way you teach, Ben, is because you have these really little subtle reframes that make a huge impact in how clinicians approach things with their patients. Yeah, genius.
Not that. But it
Don't be
would,
shy.
if you've drawn that, it will link back and, linking back to things. If we've drawn that stress beaker up with a plug
Yeah,
hole, you would kind of go, how do I make this plug hole bigger? If you've
yeah,
got more water coming out, then your bath is less filled. Then you've got resilience. Because when shit comes along, when life fluctuates, you've got resilience, you've got headspace to deal with that blip on the road
yeah,
of, a family crisis or work pressure, because
yeah,
you're doing the self-care stuff, because you're being mindful of relaxation and active recovery, diet and mitigation of smoking habits, keeping up exercise habits. So uh, thinking positively, gratitude journaling, the
mm,
psychological things that can give us resilience. I've dealt with this
mm,
before, I can deal with this again.
yeah. That's brilliant, and that brings us sort of full circle back into the concept of the DIMS, the danger in me, and the SIMS, the safety in me, which are in the core course, and the importance that they play in flare up management. Very good.
Yeah, absolutely. Yeah, it's just paying
Yeah.
attention to both sides of the coin.
Yeah, thank you. So we're gonna wrap up now, folks. Just before we talk about the course, what would be some, just from what we've talked about today, any key things that you think could be really useful for people to take away from what we've discussed, and couple of, or sort of, key message to take away from today?
Um, Ask what people are doing when life is better. I think,
I love that.
you know,
Yeah,
ask what are you doing when life is, somewhat better or you're having a good time.
yeah,
And so commonly, not even in like complex persistent pain, your OA knee, well, it was better when I was exercising. It got better, so I stopped exercising. It's got worse. Okay, go back and do the exercise. It applies throughout the complexities of pain. When people are doing the right things, often things get better. Because it's
yeah.
better, there isn't the driver to do the things that were good. So pay attention to that.
I think that's a really, really great message to end on. Thank you for that conversation, which was really interesting. So Ben, we're just going to talk a little bit now about his course. He's going to tell us what you would expect if you were to join his 2-day Explain Pain course. It is online, so you can join from anywhere in the world, and it is coming up in July, on the 10th and the 11th of July. So if you're interested in spending a couple of days learning so much more of this stuff with Ben, then the link is in the chat, and you can just click through and check out the full details. So what would somebody expect to come away with after attending your course, Ben? And what's your
I
favourite parts of teaching it?
um, I was going to say finishing at the end of the course. No,
What?
the I feel the course I teach is quite a kind of classic explain pain course. Like, we know that clinicians struggle with some of this neuroscience. We
Mm,
know that the more you know about pain, the more you realize you don't know about it. So I think we try and cover the neuroscience. We try and cover um, the science of inflammatory pain versus central sensitization, maintained pain, we versus nociceptive pain. But we also think about, how do we get these ideas across in little chunks to people, using stories, using metaphors,
mm,
using diagrams that are easy to draw up on a whiteboard or on paper, linking to sort of online resources, many of which Noi have been involved in, Flipping Pain, Tame the Beast, but also not Noi stuff. It is important that this message is not just, the Noi message. And so we link out to things like TED Talks or books or other podcasts. I want people to go away with a sort of confidence to know that they know this stuff. And like I did today, also to go, do you know what? That's a really good question, but I don't really know the detailed answer, but we've got a layer of education that makes it understandable. And maybe, I forget who asked the question, Eugenie, I think, shall we go and find out together, Eugenie? Shall we go and find out as you
mm,
and a patient? Let's go find out those details if that's important for a patient. But the patient level is not our level. Our level as clinicians needs to be deeper. The patient level needs to be engaging. It needs to be personally useful. It needs to be
mm.
relevant to their experience. It shouldn't be. What I want you to not learn from Explain Pain course with me is, um, here's a script that you say to everybody, because that just doesn't work.
Yeah. That's great. Thanks, Ben. And if anybody is interested in doing an Explain Pain course, I cannot recommend Ben's highly enough. He's a superb teacher, as I'm sure you've heard here today. He makes everything super understandable, super clear, and he draws in threads, as he's just said, from so many different places. He'll tie it all together for you, and you will leave very confident to tackle these sorts of tricky patient scenarios.
Thank you, Joe.
So, well, I've known you a long time, and we do get amazing feedback from your courses. So, 100% amazing. So, thank you so much. Thank you, Ben. Thank you for sharing your expertise with us today.
Pleasure.
Thank you to
Thanks.
everybody who's joined us live. And if you're watching on catch up, we hope you've enjoyed this clinical discussion. We hope you find it valuable, and we look forward to seeing you again really soon. Take care, enjoy the rest of your day and your weekend. Thanks,
Thanks, Joe.
guys.
And you. Thank
Thanks
you
a
very
lot.
much, everybody.
Cheers.